size of Iabp, trigger of Iabp, inflation and deflation, timing of Iabp, timing errors, variation in balloon pressure waveforms, weaning of Iabp, complications of Iabp, precautions during and after inserting Iabp, and alarms in Iabp. Introduction. Iabp is a device that increases myocardial oxygen delivery are refractory ventricular arrhythmias, refractory unstable angina, in balloon pressure waveforms, weaning of Iabp, complications of Iabp, precautions during and after inserting Iabp, and alarms in Iabp. Introduction. Iabp is a device that increases myocardial oxygen delivery by diversion of cardiac blood flow during balloon inflation to the vital organs, that is coronary and carotid circulation, and decrease in myocardial oxygen demand by decreasing the workload on the left ventricle, by decreasing the afterload via the sudden decrease of pressure in aorta by balloon deflation. Dr. Adrian Kantrovich started experiments on diastolic augmentation at Western Reserve University under Dr. Carl.
Slide didn't move.
No, sir.
Yes.
First percutaneous insertion of Iabp was done by Dr. David Bregman in 1979. Indications of Iabp for Iabp insertion: cardiogenic shock, which is secondary to acute MI, and it is refractory to medical therapy. Mechanical complications of acute MI like acute muscle rupture and VSR, refractory ventricular arrhythmias, refractory unstable angina, decompensated systolic heart failure as a bridge to definitive treatment, perioperative support for high-risk CABG and non-cardiac surgery, decompensated aortic stenosis. Contraindications for IABP. Absolute contraindications are significant aortic regurgitation, aortic dissection, presence of aortic stent, end-stage cardiac disease with no other viable treatment options, bilateral femoral popliteal bypass grafts. Here, only the femoral route is contraindicated. IABP can be inserted through axillary or subclavian route. Relative contraindications are uncontrolled sepsis, abdominal aortic aneurysm, severe bilateral peripheral vascular disease, uncontrolled bleeding disorder, prosthetic iliofemoral graft, or iliac artery stents. Parts of IABP. IABP has a distal marker which is radio opaque balloon with the length is about 22 to 26 centimeter, and it has a proximal marker. And two lumens are there. One is gas and one is for helium gas, and one more is to measure the blood pressure, and the suture pads to fix the IABP. And there is a sterile plastic sheath which permits post-insertion adjustment of the catheter position. And this is the two lumens. One is helium lumen, and another one is blood lumen, and it has radio opaque tip. The balloon volume is of 30 to 60 ml depending on patient's height, and there is helium gas line and arterial pressure transducer. Site of insertion. Femoral artery is the most common site. Axillary or subclavian artery root when there is descending aorta or iliac or femoral artery pathology. Iliac artery root is when there is a diseased or pseudo aneurysm of femoral artery through ascending aorta post sternotomy with peripheral vascular disease. Size of IABP, depending on patient's height, size of IABP can be chosen. If patient is less than 152 centimeter, then 25 to 30 cc balloon. Between 152 to 162 centimeter, 34 to 40 cc balloon. 162 to 183 centimeter, 40 cc balloon. More than 6 feet, it is 50 cc balloon. Questioning of IABP. Before inserting IABP, we have to roughly check the length from femoral artery to manubriosternal junction. Post insertion, we have to look for left radial pulse, left hand pulse oximeter trace, because if IABP is inserted deeply, then it can block left subclavian artery, which will obstruct the blood flow to the left upper limb. And by chest X-ray, we can confirm the IABP position. Fluoroscopy, mainly it is done in cath lab by cardiologists, and in OT we can use TE to confirm the position. This is the position of IABP. It is just distal or 2 centimeter distal to left subclavian artery. In the chest X-ray, it should be at the level of carina or slightly above, or it should be between the second and third intercostal space, or 2 centimeter inferior to aortic notch. If it is too far, then it can block subclavian and vertebral artery occlusion. If it is too low, it can block mesenteric or renal artery, and it can cause renal ischemia and AKI. Uh, in cardiac cycle, IABP deflation. IABP uh, inflation happens during the diastole, that is ventricular relaxation at the T wave, and deflation happens during the systole at R wave. Trigger of IABP. 5 methods can be used. ECG trigger, which uses the R wave on ECGs to start pumping. Pressure wave. The dicrotic notch in the arterial pressure wave is used to initiate inflation. Internal trigger. The balloon inflates and deflates at a preset rate, regardless of patient's cardiac activity. This mode is only to be used in situations where there is no ECG and no cardiac output, such as cardiopulmonary bypass. The balloon inflates and deflates by internal rate with range between 40 to 120 beats per minute. And ventricular or AV pacer trigger uses spikes of ventricle that has been generated by pacing box. Atrial pacer uses the atrial pacing spikes as the trigger signal. Inflation and deflation. Inflation, filling balloon with helium. Helium gas is used because it is easily dissolvable, and risk of air embolism is very less. Balloon inflation occurs at beginning of diastole after aortic valve closure, immediately after peak of T wave in the ECG during isovolumetric relaxation, which can be seen in the pressure waveform just prior to the dicrotic notch. Effect of inflation, it will increase the coronary circulation. Deflation, helium is transferred back from the balloon to the tank. Balloon deflation occurs just before the systole, before aortic valve opens. In the ECG, the deflation appear on the peak of R wave, that is during isovolumetric contraction. This is counter pulsation. And effects of deflation is mainly it will decrease the afterload, that is the resistance. So the cardiac work is significantly decreased, which will decrease the myocardial oxygen consumption, and there will be increased cardiac output. So the urine output will be high, and there will be decreased lactic acidosis. Because the cardiac output is increased, there will be decreased pulmonary congestion. Deflation is very useful in stopping unstable arrhythmias due to coronary ischemia. Timing of inflation and deflation. Um, balloon is inflated during the dichrotic notch. So diastolic augmentation happens, and deflation happens during the systole. That is the R wave. This is the unassisted systole. This is the assisted systole. This is the This is the diastolic augmentation after the dichrotic notch. Proper timing of IABP. Uh, so this is the inflation point. IABP is inflated at the dichrotic notch, which can be seen in the shape of V. This is the peak diastolic pressure, that is diastolic augmentation. This is balloon assisted end diastolic pressure, which is normally lesser than the patient's aortic end diastolic pressure. This is 1:2 waveform. Timing errors. First is early inflation. Inflation of IBP prior to aortic valve closure. Waveform characteristics. Inflation of IBP prior to dichrotic notch. So diastolic augmentation encroaches onto systole. The physiologic effects due to early inflation is potential premature closure of aortic valve and potential increase in left ventricular end diastolic volume pressure and pulmonary capillary wedge pressure because of early inflation, and increased left ventricular valve stress or afterload, aortic regurgitation, and increased myocardial oxygen demand. So this is the inflation point uh, where the balloon get inflated before the dichrotic notch. Late inflation. Inflation of IABP markedly after closure of aortic valve. The waveform characteristics. Inflation of IABP which occurs after the dichrotic notch. Normally, the inflation happens in the dichrotic notch, which can be seen in the shape of V. Here, due to late inflation, there is absence of sharp V. This is the dichrotic notch. Normally, the balloon should get inflated here. Because of late inflation, we get a W-shaped curve. And the physiological effect of late inflation of IABP is suboptimal diastolic augmentation and suboptimal coronary artery perfusion. And then early deflation, premature deflation of IABP during the diastolic phase. Waveform characteristics. Deflation of IABP is seen as a sharp drop following diastolic augmentation. This is the diastolic
ಆಗ್ಲೇ
augmentation,
ಊಟ
and deflation of IABP is seen as a sharp drop.
ವಾವ್ ಸೂಪರ್
And there is suboptimal diastolic augmentation due to early deflation.
ಇಲ್ಲ ಮಾಡ್ಬೇಕು ಈಗ
Assisted
ಬಿಸಿ
aortic
ಆಗ್ತಿದೆ
end
ನೀರು
diastolic pressure may be equal to or less than unassisted
ಕ್ಲಾಸ್ ಇತ್ತು ಕ್ಲಾಸ್
aortic end
ಕೇಳಿಸ್ಕೊತಾ ಇದ್ದೆ
diastolic pressure.
ರೆಕಾರ್ಡ್ ಆಗಿತ್ತಲ್ಲ
Assisted
ಮುಂಚೆ
systolic pressure may rise. The physiological effects due to early deflation are suboptimal coronary perfusion,
ಓಕೆ ಓಕೆ
potential for retrograde coronary
ಸ್ಯಾರಮ್
and carotid blood flow. Angina may occur as a result of retrograde coronary blood flow,
ಬಾಯ್ ಬಾಯ್
suboptimal afterload
ಚೆನ್ನಾಗಿ ತಿನ್ನು
reduction, and increased myocardial oxygen demand. In early deflation, um, there is a U-shaped curve after the sharp drop, and peak systolic pressure is greater than or equal to uh, assisted peak systolic pressure, and balloon assisted end diastolic pressure is more or less equal to patient assisted end diastolic pressure. Normally, balloon assisted end diastolic pressure will be lower than patient's aortic end diastolic pressure. Late deflation. Late deflation of IABP during the diastolic phase. Waveform characteristics. Assisted end diastolic pressure may be equal to the unassisted aortic end diastolic pressure. Rate of rise of assisted systole is prolonged. Diastolic augmentation may appear widened. The physiological effects due to late deflation is there is a significant increase in afterload. Normally, the deflation helps to decrease the afterload, but due to late deflation, the afterload reduction is essentially absent. So there is increased myocardial oxygen consumption due to left ventricle ejecting against a greater resistance and a prolonged isovolumetric contraction phase. IABP may impede left ventricular ejection and it will increase the afterload. This is the normal balloon pressure waveform. Uh, uh, this is a balloon pressure baseline, and this is inflation overshoot, and this is the plateau phase. The In the plateau phase, the balloon is at the maximal inflation. After that, rapid deflation occurs, and there is deflation overshoot, and the pressure reaches to the baseline. This is normal balloon pressure waveform. Now, variation in balloon pressure waveform. uh, increased duration of increased duration of plateau due to longer diastolic phase. Uh, this occurs in bradycardia, and in tachycardia there is decreased duration of plateau due to shortened diastolic phase. Rhythm. Varying RR interval result in irregular plateau durations. And in hypertension, there is increased height of the waveform. That is, amplitude is increased, and in hypotension, the amplitude is significantly decreased. If there is any gas leak in IABP, uh, the pressure waveform will fall below the zero baseline. This is the zero baseline. If there is any gas leak, the pressure waveform will go below the baseline. This can be due to a loose connection, a leak in ABP catheter, water condensation in external tubing, a patient who is tachycardiac and febrile, which will cause the increased gas diffusion through ABP membrane. When the catheter is kinked, this waveform is kinked. This waveform is caused by a kink in the catheter tubing or improper IABP catheter position. Waveform characteristics: a rounded balloon pressure waveform, and there is a loss of plateau. Normally, there will be a plateau after the overshoot. Here, the plateau is lost, resulting from a kink or obstruction of shuttle gas. Reasons: the balloon catheter may be kinked. IABP is too large for the aorta. IABP is partially wrapped. Water condensation in external tubing. Most commonly, this type of waveform is due to is seen mainly because of a catheter kink. The catheter is most commonly kinked in the insertion site. Physiologic effects: if catheter is kinked, the balloon cannot empty, and balloon deflation could be delayed, which results in failure to improve afterload or an increase in afterload. Weaning of IABP. IABP can be weaned when patient is not in cardiogenic shock anymore, and adequate BP with little or no inotropic support. Reasonable target values to aim for prior to weaning are a map of 65 millimeter of mercury, and if monitored, a cardiac index of greater than 2 liter per minute per meter square. Weaning of IABP can be done by two ways. First, by reducing the ratio of augmented to non-augmented beats. This can be done by reducing the augmentation frequency every 1 to 6 hours from ratios of 1:1 to 1:2 to 1:3. If a ratio of 1:3 is tolerated, normally for more than 2 hours, then the device should be put into standby and then only removed. And An alternative weaning method is to decrease the balloon filling volume by 10 ml every 1 to 6 hours until a filling volume of 20 ml is reached. During weaning, IABP should not be left in situ once switched off, as this is associated with a high chance of thrombus formation on the balloon and distal embolization. A ratio of 1:3 should also not to be used for prolonged periods, as this is also associated with a significant increase in thrombosis risk. Complications of IABP. Most commonly, IABP is inserted through the femoral root, so some amount of blood supply to the lower limb is compromised, which can manifest as a limb ischemia, bleeding at the insertion site, infection complications, and mostly at the insertion area, aortic dissection, which can happen from tearing of aorta during the balloon insertion, and there can be thromboembolism, false aneurysm, aortic valve rupture if it is inserted too deeply, reduce in urine output if the IOBP uh, is obstructing the renal artery, incorrect timing causing increased afterload and stress of left ventricle, balloon catheter rupture and gas loss, hemolysis due to mechanical damage to red blood cells, acute renal failure, thrombocytopenia due to mechanical damage to platelets or due to heparin administration. Precautions during and after insertion of IABP. End of the patient bed should not be elevated to more than 30 degrees to minimize proximal catheter migration. We should regularly check for hemoglobin and platelet count because of the risk of bleeding, hemolysis, and thrombocytopenia, which is caused by mechanical damage of IABP to RBC and platelets. We should regularly check the renal function because of risk of AKI secondary to distal migration of IABP catheter. IABP must not be left in standby mode for any longer than necessary and never longer than 20 minutes in view of high risk of device-related thrombus formation. Patient should be anticoagulated. ACT should be around 200 to 250 seconds. No blood samples should be taken from balloon arterial pressure line. Early assessment of signs of peripheral hypoperfusion, test color, capillary return, sensation, presence of pulses by palpation or Doppler studies. Early perfusion assessment of left upper limb, which may become compromised in the event of proximal migration of catheter, which will compromise the left subclavian artery blood flow. Alarms in IABP. Uh, no trigger alarm. This means that the IABP has lost its tracing of ECG or pressure and is unable to time the inflation and deflation. The action is to reconnect the ECG leads or pressure cable or change the ECG leads or tracing, leading to which will lead to obtain a better trace. IABP disconnected alarm. This means the IABP catheter extension tubing has been disconnected and the pump will stop working. Action: reconnect the extension tubing. We should press the IABP fill button in the IABP machine for 3 seconds till prompt is on the screen, and the press assist or standby to start pumping. Rapid gas loss alarm. This will appear if there is a leak or hole in the balloon or extension tubing. This means the balloon may be ruptured. There will be flecks of blood in the tubing. Action: if the balloon is losing its gas and filling is frequently necessary, or blood flecks have been identified in the tubing, then we should stop the pump. It will mean that the catheter will need to be removed or replaced. We should check for all connections for any leak or disconnections. Check IABP catheter alarm. This means that the IABP catheter is either kinked in situ or at the insertion site, or it has not unwrapped fully in situ. Action: we should examine the catheter and extension tubing for any signs of kinking. We should ensure that full augmentation is on, making sure the balloon has the ability to expand. Should examine the skin insertion, as this is the most common place for kinking of catheter. Low helium alarm. This means that the supply of helium is less than 24 fills. Action: the helium cylinder needs replacing. We should ensure that the zero ring is not dislodged while changing the helium cylinder, as this ensures the seal. Low battery alarm. This means the battery has less than 30 minutes of operating time. Action: ensure that the balloon pump is connected to the main power at all times to recharge the battery. IABP failure. IABP failure alarm. This means that the IABP console fails to pump, usually as a result of electrical malfunction or the presence of blood in the condensers. Action: we should disconnect patient from the Iabp console, obtain another Iabp console. This should only be attempted if the balloon is not ruptured. If the balloon is ruptured and if you are changing the Iabp console, the same problem will occur again. Augmentation below set limit. This means that the augmented diastolic has fallen below the alarm set. We should review the alarm set and consider lowering it in line with the patient's progress. Thank you, sir.
Okay. This is a okay presentation for writing an exam paper. But a few comments I want to make. One is you did not talk about the principle of IABP at all, what Kantrovich envisaged. And the whole thing is dependent on something called counterpulsation. During
Yes,
counterpulsation, why do we call it counterpulsation? That means the balloon inflates during diastole and deflates during systole. That means it is working against the principle of the heart function. And why is it
yes,
done so? Because in diastole, there is a shift of blood about 40 ml, which is the volume of the balloon in the balloon catheter, back
yes,
towards
sir.
the aortic valve. So
Yes,
that
sir.
is why at that point of time, the aortic valve is closed. So the sinus of Valsalva will distend and there is increased coronary blood flow. So this is counterpulsation of because the diastolic, the coronary blood flow is always during the diastole. So
Yes, sir.
40 ml of blood goes back into the ascending aorta, which perfuses the coronary blood vessels, and some amount may go into the cerebral circulation as well. The second thing is that it gets deflated during the R wave, that is the beginning of systole. That means there is a sudden release of the afterload because the balloon is causing there is when the balloon deflates, the more blood goes into the distal circulation, so
Yes, sir.
the afterload in the ascending aorta is decreased and the ventricle is able to pump better. So
Yes,
this system, this principle has to be understood by all of you. So unless the afterload is reduced, the ventricle will not be able to pump against the increased afterload. So
yes,
this
sir.
is used for recovering ventricles.
Yes, sir.
If the ventricle is beyond repair, if the ventricle is beyond just saying what you call, if the ejection fraction is less than 20 and the ventricle is not able to
Recover.
recover, then the IABP is of no use.
Yes,
So
sir.
then maybe you have to go into something's happening with my okay. Uh, Sorry, can you hear me?
Yeah.
Yes, sir. We can hear you, sir.
But I'm not able to see the screen suddenly. I don't know. Okay. Anyway, so if the ventricle is failing beyond recovery, then it is necessary to use a VAD or even go on to ECMO. So
Yes,
that is one thing. The principle of counterpulsation should be well understood, and that is why the balloon gets inflated at the dicrotic notch. What happens at the dicrotic notch? The aortic valve closes. So that
yes,
once the aortic valve closes, there is increased volume in the ascending aorta, which gets perfused into the coronary artery. Next, you should have talked a bit about the insertion techniques. There are at various sites. You have to talk about the percutaneous Seldinger technique, open technique, where
femoral,
you expose the femoral artery
femoral
or the
artery.
axillary artery, or put an interposition graft, an 8 graft, so to prevent your ischemia of the lower limb. All these things are important, and where and how you're going to do these things. So insertion is important, and you did not mention anything about the removal of the balloon catheter. That is also exceedingly important. The removal of the balloon catheter after weaning should be done with the pressure on the femoral artery or the axillary artery for a minimum of almost 15 to 20 minutes, 20
20
to
minutes. Yes,
30 minutes you have to get. There are different pressure devices that are designed, but they are not very good because they all lead into false aneurysms. So most of them, I mean, not all, but quite a good number end up with having a false aneurysm in the femoral or the axillary artery. So it is always better to put pressure and stand on that pressure for about 30 minutes before you remove that pressure, and then make sure that the distal limb perfusion is good.
Pressure.
So this is a very important thing in the ICU. As a resident, you are expected to do this. So
Yes.
otherwise, you'll end up with limb ischemia or a false aneurysm of the artery that you are used.
Yes,
So
sir.
these are the things. And then, of course, the trigger, you should have mentioned that the standard trigger is the ECG. ECG is all right.
This is
And sometimes when the ECG is not picked up, then the pressure waveform is used, or the intrinsic basic rhythm from the console itself. But you must also know how to adjust for the augmentation during arrhythmias, during
yes,
AF, and during supraventricular arrhythmias. This is very important because those things were not there in the initial models of the Iabp. If there was arrhythmia, we were not able to do the diastolic augmentation during that time. But now the later machines and later models have incorporated that. So you should know how that is done, and where the trigger is, how the trigger works during AF.
yes, sir.
So you should have included that in your talk.
Yes, sir.
Okay. So that is the main thing that. But overall, you have concised all the things that have to be done, and it is good for so much to write for a 20-minute, 18 minutes or 20-minute exam question.
Yes,
So
sir.
you have covered most of the things, I think.
Sir. Thank you, sir.
Sir, any comments from your side, sir?
Yeah. Only thing is, when you started with the indication for a IABP, when you
Yes,
started with
sir.
the wrong things first, as myocardial infarction, cardiogenic shock, uh, very sick patient for coronary angioplasty, but you should, if they're all surgeons, you should have started with the indication. Uh, Patient post-operative low cardiac output syndrome, and you cannot be weaned off. Those are the things you should have started, given more priority, and then come to the cardiogenic shocks later. Of course, the
Yes, sir.
patients with post-myocardial infarction, ventricular septal rupture, we preoperatively put IABP. Similarly, some very sick patients for coronary angioplasty also on IABP. Those things, are okay. Then you should have something more. What is the usually how much increase in cardiac output? They say IABP is the basic mechanical thing which circulatory assist device. It's about 30 to 40% increase in the cardiac output.
Yes,
The heart rate usually comes down. The pulmonary capillary wedge, if you have got a Swan's Ganz catheter, it comes
yes,
down. Because we know that the coronary artery supply 70% occurs during diastole and
yes,
30% peristaltic. So that's importance of so you explained that how it reduces the cardiac work, the oxygen consumption demand and consumption ratio. Okay. Then the
yes,
other thing is you mentioned most of the how the variations of the inflation, deflation, all those things you explained. That's fine. The other thing is that you didn't refer to most of the latest things, at least do some Google search and said, what is proactive counter pulsation? I just looking into the Google yesterday. Proactive, it's a new technique that, there's at the tip of the balloon, there's a fiber optic sensor, and there's an algorithm that sensors the systolic flow. And because the systolic flow starts reducing, that's the time going to be the aortic valve closure. So with this proactive catheter, you can predict the aortic valve closure and the balloon inflation can be done exactly during the diastole.
yes, sir.
So that is the proactive. So this new proactive counterpulsation, it senses the systolic flow and predicts the aortic valve closure so that the balloon timing can be correct. Also, you can read the pressure, the systolic, the augmented pressure and the things. It's more important because it works atrial fibrillation, tachycardia in every case. And also when you're moving a patient from one to the ambulance and when it's moving and your ECG trigger and the pressure trigger may not work. So the
Yes,
proactive counterpulsation is the latest thing that you should have referred. I just referred yesterday and found
yes,
that this is the latest thing in I don't know whether they use this in our hospital or not. The proactive counterpulsation. There's a name for that company which makes it, the latest thing. The other thing Krishna said also, previously, I remember before the percutaneous insertion came, we used to put a graft, as Krishna said, put the
Okay,
balloon through
okay.
that and tie that onto the graft, And so
yes,
Okay.
sir.
uh, when you remove it, you have to repair
Nangin
the
wala, ta jao.
femoral artery. Nowadays, of course, most of it's a percutaneous and a sheathless because the sheath itself is usually 8.5 to 10.5 French, That makes a bigger hole. And as Chris
Yes,
said, 30 minutes on the clock you have to press. And at the end of that, you have to give a pressure dressing to the femoral artery. Then, of course, if a old patient with aortic disease, abdominal aortic disease, of course, when you're doing open heart surgery, it's better to do it through the ascending aorta itself. At the end, you have to remove it. You have to open it. So whenever you present, you must refer to what is the latest in this thing. And I think generally in your hospital, I noticed the number of times used Iabp has come down and the ECMO has gone up, no? Isn't it? Post-operatively.
um, we use both, sir. Like,
I thought in most places the use of Iabp has come down and the ECMO has gone up. Is it true or not?
I think no, sir. We are using IAB more in
It's,
our hospital.
it's still extensively used. Okay. I read in Western literature, I find that actually. Because it gives much better support. The ECMO gives much better. I told you the increase in cardiac support is only about 30% in IABP. The patient
Yes,
really requires that ECMO gives much, we know arterial ECMO gives much better support. Okay. Anything else?
Just like the valves,
Yeah.
there are different models of IABP. This thing in our days, it
Yeah.
used to be only datascope. Then
Yeah.
then the arrow came in, and then there are newer models, and then the advantages and disadvantages of each of these things should be known to you. And especially with the advances in each company claims that their insertion sheath is smaller and smaller, and you can put a small even in a smaller vessel. So these are different. Find out what are all the different models
Yeah.
that are
Yeah.
available now, and then you should
yes,
know
sir.
what it is.
Yes, sir.
And yeah, complications, bleeding, false aneurysm. You said that distal embolization of the ischemia. Uh, Other things are okay. Yeah, you so all these things, all these questions that we discussed should be added into your presentation,
Yes, sir.
and so that it becomes a complete this thing
Yes,
answer for your exam. It's good to
yes,
know these things. Yeah.
You
Okay.
mentioned the hourly uh, distal pulse checking
yes,
notified
sir.
by palpation and by Doppler. That's very important. And in some cases, there may be ischemia, and some of them may need fasciotomy because if the calf swells up, so it's fasciotomy. The other thing is that balloon is at a lower level, and the visceral branches are affected, the renal arteries affected. Some of them may need even dialysis. And also nowadays, because we have got TE, we know exactly where, we don't have to do X-ray, we exactly know where the tip of the balloon is.
Yes, sir. Yes,
So low, lowering it, going below the diaphragm and all doesn't occur if you are careful. Okay.
Right. Any other questions from anybody? Why are the final years not attending these classes? classes. I don't know.